Hello, welcome to Out of the Fire podcast, where we talk about interoperability, fire, digital health, and all sorts of different projects that are happening all across the industry. I would like to welcome today Mark Fleming to the show. Mark, do you want to introduce yourself?
Yeah, hi, Gene. So I'm Mark Fleming. I'm a senior director at Availity. So I'm responsible for our prior authorization, interoperability, and portal solutions, where we help both payers and providers connect and manage that process. So prior to Availity, I actually have 25 years in healthcare. It's hard to believe. Started off at Epic back when Epic had about 500 employees, so a little bit different than now, but really spent my majority of time in revenue cycle at a large academic. So both at the front end, so as a manager and director over patient access, and then spent a number of years over claims and remittances and our EDI solution. And while they are implemented 270, 271, notice of admissions, which is a 278 X12 transaction for that's kind of built around prior authorization, and then decided to get back into the technology space about 8 years ago. So went to a startup that was acquired and was at Change Healthcare for a while, and been at Availity now for the last 3 years.
That's awesome. So obviously all these years in healthcare, do you want to just give your quick take on like the state of interoperability?
Boy, that's a big area. So I think what I've really been focused in on for the last 8 years is really around prior authorization. And this was a problem that I had when I was actually at the health systems. I had staff, about 40 staff, and part of their responsibility was to submit prior authorizations. And generally at that time, they did it via fax and phone. Towards the end, we got to portals, and that was pretty exciting. But really, that model hasn't changed much. The 278 transaction, which was an X12 transaction, was supposed to help fix that, but we really don't see much utilization of that. It's about a third of the transactions are X12, a third are portal, and a third are still fax and phone. About 2 years ago, CMS introduced a new mandate for fire, CMS 0057, and I'm really excited about that as an opportunity for making a real change in the prior authorization process.
Yeah, so let's go to CMS 0057. We have 72-hour turnaround time, right, on that, and where currently it's like anywhere between a week and weeks, right, on the prior auth. I actually have an interesting use case recently that I went through with my kids while getting their ADHD medication approved. So my provider actually submitted a prior auth to, and I think it's Cigna, and they came back and they said like, well, you did not submit all the appropriate documentation for why you're looking to start this particular medication. And have you tried these 3 other medications? And have you submitted, like, there's 4 types of evidence of like, yes, you've tried this, it doesn't work, this is why. How do you see this working in this new, world of
Yeah.
CMS 0057? And like, how could have this worked to, like, basically, instead of waiting, I think we have to wait like, I don't know, a week or 4 or 5 days to resolve all this back and forth between the provider and the insurance company. And I think there's actually PBM that's in the loop too.
For sure.
How does this work in the ideal scenario?
That's a really great example, and it's something that I've struggled with as well with my family. And so I think the things that really get addressed with the new Fire APIs is first is a concept of transparency. And transparency means 2 different things. The first off is either at the time of ordering, and so in this case for that medication, or could be a service, a radiology service, or something like that. You have a real-time transaction with the payer to first off know if an authorization is even required. And also, as part of that transparency piece, to know what clinical information or what clinical questions are needed or what medical policy is being used. And so what that really tells you in the case that you had is they submitted information and then they found out, like, give me something different. So the idea being is letting the providers know upfront, or the submitters upfront, here's what's needed. This is the type of information that's needed. And so the right information gets submitted the first time. The second thing that starts to happen is no more faxes, hopefully no more faxes, no more phones, no more portals. And so that triggers directly from their EHR routed to the payer in real time. And that information is flowing back and forth. And so the cases where today somebody logs into a portal and maybe they did upload the clinical documentation, but then they have to log into the portal again the next day. And what we're really starting to envision is a case where that order's placed, The provider knows right away what that service is. At the time of like checkout, you could then schedule that service. Right now, when people check out, like they'll schedule it out 2 weeks because they want to give time for that prior authorization. If I knew right away that auth wasn't required, or in some cases, we're starting to see where as you start submitting that clinical data, payers are making determinations in real time. And so leveraging some of the new AI technologies. And so you start getting that information in real time. So they're not scheduling out 2 weeks, they're scheduling out 1 day or 2 days, whenever the next slot is open. So it's a real change. And they're so real excited about kind of the different features that are coming with Fire to improve that transparency and that efficiency around prior authorization.
Yeah, that's great. I think like we can all think about like we can do so many things that are instant. So everything like in our lives right now, like I don't know many things where like you submit something, you have to wait unless you're like renewing your passport, right? Or like you're getting, even like something like LLC, you can open up an LLC in like an hour, right?
Mhm.
And you can get
Right.
literally like a lot of times. So to have this like really cumbersome process around this is like really, crazy. So, okay, so going back to the mandates themselves. So
Hmm.
we're talking
Yep.
about January 1st of 2027 that the full Fire API mandate, right? So what does that mean if you're a payer, and then what does that mean if you're a provider? Can you like
Yeah.
deconstruct that for everyone?
Yeah, great question. So the mandate is more than just prior authorization. There are other APIs that are included in that. Payer to payer is one of them. Provider access and a patient access as well. So it's really the idea is opening up the ability for providers and for other payers to exchange data leveraging the Fire APIs. For prior authorization specifically, of course, it's only required for Medicare Advantage, Medicaid, and those on the exchange. That being said, AHIP, there we had about 50 payers who committed to not only for those services, but all of their lines of business, including commercial. So we are really expecting a pretty big change. That being said, I'll say kind of for the pairs, I wouldn't expect like Nirvana January 1st. There's going to be a transition period. There's going to be learnings. This is more than just connectivity. Pairs have been building their systems for years, and they're really structured for their processes. So in many cases, they're really having to deconstruct. Maybe there is auth required rules where in their claim system or in a Excel spreadsheet, their medical policy where it might have been in a PDF somewhere. Now you have to pull that all out and digitize all of that work. So I think there's going to be time and there's going to be, work during that first year. I think on the provider side, you have something similar. They were not mandated to connect, but they're often the ones feeling the most pain. They're the ones that are having to fax and then jump out to the portal and do the chair swivels, copy and paste. And so they're the ones that I think are most interested in saving that effort. Da Vinci is is a point to point solution. And so they're taking the idea is generally modeled was, hey, provider connects to a payer. On the provider sides, we've been talking to them and we actually look through our data. We see about most health systems, I'll say average size health systems, submit to 40 different payers per month. And we see some close to 80. We know that health systems are not going to submit up to 40, build 40 different implementations. They're looking at most health systems are looking kind of that top 5 or 10 or leveraging a network to build this out. And so, and TEFCA unfortunately has not kind of moved into this operational process. It's very much still focused on the clinical. And so I think there's going to be an opportunity, at least in that short term, to be thinking about what does a network look like and how do we build that out. So now we have a bunch of endpoints that payers are setting up for January 1st. We have a bunch of providers that want to connect and how do those get connected? And there's of course other things in the mandate. You talked about response time. Some of that response time actually got in January 1st of this year. And we've definitely had payers trying to respond back faster, making changes actually in their portal workflows to gather the right information faster. But as you know, if they don't have the right information, they can ask for more and that kind of resets some of those clocks. And so there are definitely cases where this process needs to be improved. And we definitely, as we move towards electronic prior authorization, we'll get there.
Yeah. And I think there's a lot of things worth mentioning. Like I think pharmacy is not part of that.
Yep.
January 1st. Although there's interesting, I've heard that there are some state mandates that
Hmm.
are kind of touching on the pharmacy. And pharmacy is its own big kind of, kahuna. And okay, so I've looked up Availity, and you guys actually ran a reference implementation with Humana and Athena, if I
Hmm.
understand correctly.
Yep.
And can you speak to some like learnings from that, like what's worked and what
Yeah.
still was like hand
Yeah.
wavy?
Well, actually, I think there wasn't much hand wavy there. But you're right, it was that kind of point to point solution for a set of services. So it wasn't every service under the sun. It wasn't every workflow. What we really focused in on, and this was actually, went live about getting close to 2 years now, allowed the provider at the time of order to place the workflow. And what's really interesting is they actually changed and rebuilt. Athena did their checkout process to have the information about that order right at the time of checkout. So they knew right away at the time of checkout that a prior authorization wasn't required, or even that they could submit that the individuals at checkout could submit that authorization and get, in some cases, approval in real time. And we definitely saw that they have a specific use case that, yep, they've submitted the information, they submit the clinical documentation, they get that back, and that approval is happening kind of in real time. What that really allowed them to do is to move scheduling. Previously, the checkout would be like, here's a phone number, go call us, or we'll schedule something out, and really pull that in. And so that's been live for getting close to 2 years now. Fire transaction, we start early to know if an author is required. Fire transaction to get the medical policy questionnaire, and then submission. In addition, we're pushing back data anytime the payer changes the status. That information is going to us. We push that back to Athena. So Athena is getting notified of approvals or if information is needed. So it's not the, hey, is it approved yet? Is it approved yet? It's very much a bi-directional flow. It's as we envisioned it. And it's been really, really successful. That was real learnings into building out the new Fire platform. So we're taking that from kind of those point-to-point solutions into building out a real network. We have a lot of integrations with our great payer customers. And the same way we work with our provider customers as well as that clearinghouse. And it is that opportunity to start building something a little bit from scratch, which is always fun if you're in product. But it's also those cases where you're starting to look at kind of trying to solve the overall problem. And we're excited to be working towards that. Testing is already underway for with ourselves, with the providers, with our payers. We're having integration ongoing with the Blue Cross Blue Shield Association. So that's underway. So we're doing a lot of work. Transactions are moving back and forth. I'm bullish on meeting the 1-1 and having a lot of APIs live and a lot of transactions going well. That being said, it's, there will be some challenges as we get through it, but I'm definitely overall positive that we're going to be in a much better place a year from now. So I'd love to come back in a year and give you an update on how things are going.
That's awesome. Yeah, that would be great. I personally have worked with Fire Data over the last 4 years and know a lot of even though you may have Fire API stood up and, technically you're compliant, the data itself flowing through that is often wrong, stale, or, shaped differently than the spec.
Mhm.
How are you dealing with some of that? And I'll just give a plug that I have a project called HealthClaw that is an open source layer on that tries to give you kind of like an assessment of how good the data quality is. So, like,
Mhm.
how are you guys dealing with that?
Yeah. I mean, I think that's going to be one of the challenges. And I think it really started with the partnership and the conversations we've been having with both the EHRs and our payers. I think in all cases, the North Star is our Da Vinci guides. And part of that being on the burden reduction group, we've been involved in those conversations as part of that work. And I think understanding that's the goal. I think the second piece of this is we've been doing prior authorization electronically for years. We have 278 transactions, we have REST API transactions. So we're used to looking at the data. As part of that process, that really gives us a good understanding when we're talking to a payer. It's like not enough to just like get the data. And it's also when we're talking to the providers, we kind of have a pretty good idea of like, yep, this is what the payers are expecting. That being said, I mean, that's going to be some of the learnings that we're expecting to happen towards the end of this year as we get into testing and more into next year as we learn, hey, these are the capabilities of this EHR. How are we going to manage that use case? Hey, for this specific use case, how does that address? We had a really good example. The current specifications that most of the payers are using doesn't have a specific flag to separate out like inpatient from outpatient services. That's something super important on the payers systems. They're used to having that type of information. And so that being said, is included in the upcoming spec. But we've been talking to Epic. Hey, how are you sending that information? We've talked to Oracle as part of the Cerner implementation. How does that work? And making sure that we're talking to payers as well as how we're receive it. And in some cases, trying to better align those processes. I think that's what we've really seen is that the industry's done a really good job of coming together, understanding that we're all starting from the spec. I haven't seen a lot of cases where we're leveraging custom extensions. Hey, I need this piece of data, otherwise it's going to fail. So excited about where we are in the overall process around getting ready for the end of the year.
Question to you on the X12 278 versus the Fire PAS. Which is the preferred way? Obviously, if you're doing already X12, you can utilize that. But is there a benefit to going for the Fire?
Yeah, I mean, yeah, I think that's a really good question. I think the submission piece, PAS, which is prior authorization support, so that specific API today in the X12 278 transaction, it doesn't include any of the clinical information. So it's a separate transaction. That's the 275, and so it's linking that information together. In addition, Fire does have some additional fields that they support, of course, optional, and an error comes back a little bit different structured. That being said, what's needed in a 278 is the same information needed in prior authorization. We want to know about the member. We need to know about the services. We need to know about the providers, when the service is happening. That same information, whether it's a Fire format or 278, maps the same way. I think what gets to be really interesting around Fire is the other APIs. The one that's done at the time of ordering, call coverage requirements discovery, or CRD, and the one that's triggered back about the medical policies, called documentation templates and rules. Those APIs now build out the full workflow as part of the prior authorization. Previously, providers would gather all the information, kind of throw it over the fence, and hopefully that you got the right information there. And you talked about the example earlier about, hey, they gathered information and submitted it and then found out you need to have 10 other things. And so the model is really going to be different. So it's gone from this transaction we just send back and forth to an entire workflow. And I think that's the real change, and a real change in the mental models of how we think about prior authorization.
Yeah, very interesting. And I think like we talked about the benefits of Fire, and a lot of times we've seen in the past, particularly I think with the payers, where a lot of these mandates, we're seeing the patient access APIs have been actually around for a while, right? Like, and a lot of that kind of been as a checkbox compliance exercise, and they're essentially not being used, but also because it's really, I think it's you have to remember your password, you have to go in there. So let's talk about like the CMS health tech ecosystem and like the new kind of like federal initiatives that we have going on this year from CMS, and why that matters, and particularly how does that also align with the 0057.
Yeah, I mean, I think what you're really starting to see is our CMS group has been very proactive in trying to engage and push the industry forward. I think not only we talked about the 0057, they also have a proposed rule, CMS 0062, I believe, and that one expands the 57 to include things like medications, and so that is coming. We have the CMS Aligned Network. So again, I see cases where they're doing what they can to help kind of give that foundational base of, hey, here are the minimum requirements, and then also kind of giving I don't say incentives, but at least giving the opportunity for people to kind of join in and move forward. I think that's a really nice model. I think the idea is saying, hey, we want to hold everyone to a same standard. This has to work. And there also some value of actually pushing some groups who are interested in doing something more advanced ahead. I think we're definitely going to see that not only around the CMS aligned networks. I think there's a lot of cases where things like people starting to think about how we're going to leverage AI, how we're going to leverage some of the other tools that are kind of like weren't thought about a number of years ago, and now how do we start building those into these types of processes. And so I'm really interested to see where this goes. Right now a lot of the processes are still done mainly by staff over from fire side, and on the nurses on the payer side, kind of doing this process. And so I'm excited to see how this all ends up, but we'll see.
Yeah, I think this is a great effort. I think what they're seeing traditionally in the industry, right, is like you have kind of innovation happening in pockets. You may have one company that's really innovating in a certain space, and really, unless they, open source that work or they publish, it's really hard to spread that experience around. And many companies are essentially doing the same thing at the same time, but not talking to each other, right? So we've seen that. And like to be fair to the HL7 community and Fire, like people have been at the table for a very long time. Fire has been around since what, 2012.
Sure.
Around there's certain folks that are part of the industry and know other people, and they sit down, they have these connectathons, right? But it's like in reality, that's a very small part of the industry, right? That's involved, and that's something I've seen also. So having this additional avenue, which is the CMS health tech ecosystem, which allows companies essentially to work depending on how fast you want to go. You can participate in this mandate, in this pledge. So
Mhm.
maybe you could talk about some of the pledges that you guys, as Availity, you guys are
Yeah.
participating in, and then what have you seen so far that makes you, go like, this is exciting.
Yeah. So we've actually joined Trebuchet. Trebuchet is one of the groups that is kind of building around kind of a standardization approach for building out connectivity. And love partnering. Actually, the call is later today where we're getting on to start. So that'll be what I'll be doing this afternoon is jumping on a call, talking about how we start to connect. And now really is the right time. The hackathons are great. I think that's great to have everybody in a room and get one transaction flowing back and forth and to see it. What we haven't seen a lot of cases though is that hackathon gets to that next stage. I mean, you talked about the work that we did with Humana and in Athena, and that was non-trivial work. That was built off of that initial work, but then it was another 6 months or 8 months, sometimes a little longer to kind of actually do the full implementation, even though that connectivity happens very fast. We recently just upgraded to the latest version of Fire. We went from the 2.0 to the 2.1 version, and that was working again with Athena and Humana on that process. And it doesn't look like much when you look at the specification going from one version to the next. Doesn't look like much, but when you actually sit down and map it, and then how do we support both the old version and the new version at the same time? Especially us sitting kind of in the middle, really thinking about that process. We want to build a platform that's extendable. We know not everyone's going to upgrade at the exact same time. So how do you support those different versions is a really interesting challenge. Especially when you start to think of this at scale. I think in most cases we're seeing a pretty standard approach coming out for January 1st. But my expectation is DaVinci's moving really fast. The burn reduction group is great to be part of, and they've already have the next set of rules, the 2.2 rules, at least for our prior authorization ones, are under consideration right now. We expect those to be finalized soon, and then we'll have the conversation of like, when are we going to support the next version? And when is a specific payer going to support it? When is a specific EHR going to support it? And how are we going to manage that workflow? So I think there's a lot of different great conversations, whether it's happening in Trebuchet about how to build out the connectivity, whether it's happening in the DaVinci burden reduction group, whether it's having about CMS with the aligned network groups. And so I think where there's just a lot of different conversations happening, I think my recommendation is to get involved. And I think get involved in the conversations are great. I think the next thing is we're at time. There's going to be APIs available, if not now, in the next handful of months. One thing that we've been really interested in doing is understanding where some of the challenges really are with that connectivity. Our set of APIs are going to be in our developer gateway. If you're a provider or submitter, you're going to have access to those. We're laying on top of that, our development portal, kind of an interaction layer, an MCP for developers to help discover. We know it has to be available for humans as now for agents to be able to connect to us. And so you're starting to see these cases where how do we end up going faster? How do we make connectivity faster? One of the challenges with the point-to-point solutions is that there's a lot of connectivity that has to happen, and how do we make it better? But it's really up to the HIT vendors to think about how can I make this as easy as possible to build these connections fast, so that you don't build the APIs and no one can come.
Yeah, to your earlier point about DaVinci, I think we're trying to standardize the spec, but it's not a monolith. It's not a one
Mhm.
point in time. It's really designed to solve a particular problem, and the way you solve it is implementation becomes a test. And now, obviously, I'll take a contrarian viewpoint where I actually think that agents are your consumers more so than even developers. Because if I look at like a lot of the folks that are traditionally sitting in those healthcare IT roles at a payer, at a hospital, like they're not learning the fire spec anyway, right? Like they're not going to be there learning this. Like they have, limited amount of time in a day. They're not joining a connect-a-thon. It's very rare that you'll have resources to be able to do that. That's why there's a huge need, and I think a huge value that somebody like Availity and somebody like a vendor that can spread this cost around many, many, many different clients to invest in the ability to develop these connections. And so I think it's not that the agents are going to be replacing all of those health IT people. It's just that now the health IT guy that's like, okay, I'll get back to you in about 4 weeks.
Mm.
They're gonna have agents that are kind of getting back to you immediately. And so it's extremely important to be like forward thinking on this. It's implementing the spec, but doing so in a modern way that's not expecting some human to still press a button. And it's funny, but I think a lot of times we're still in that mode. I had a great conversation with David Pike and other folks from the Fast Security, initiative and working group. And what we're talking about is this trust, the equation of trust, but it's also like we're right now set up. Fire basically works on a point-to-point, human approval, framework. And how do we get how do we get beyond that? How do we get beyond that? Organizations can talk to each other and ultimately interact and exchange this data where the human is in the loop where they need to be, but they're not in the loop where they don't need to be. How do you envision this working a really true end-to-end in the prior auth? Because to me, prior auth is like the main use case for that in the organization to organization exchange.
Yeah, I think you hit on one of the real challenges around this is that concept of trust and in building out a network. As part of I was at the health systems when we first implemented the HIEs and sending the clinical data between multiple EHRs. We have me working in Epic, but I remember working with health systems in our community who are not on Epic. And then, we all at the beginning, every patient had to sign a form for us to anytime we exchange any piece of data, we had like electronic signature pad, and then we had like an extra one if it was going to go like outside of the Epic workflows. And so there was a lot of that. And then I remember we met every month and everybody had to share our metrics, like who said no, who said yes. And then after 2 years, we stopped capturing everybody's signature. And so because we had implemented processes, because we had built out that trust, and because those HIE structures had put themselves in place, and I'm expecting something similar to that to happen. There's definitely the need for trust. There can be bad actors. And I sometimes, worry that if somebody could just kind of click through something, get access to something they want, then we will have somebody come in saying like, nope, we do need to have a bunch of steps in the process. That being said, as part of Availity's process, when we onboard a new submitter, we go through a verification. It's just not anybody can be a submitter. We do some verifications. We know who they are. And that's true whether they're going to access our portal to be a submitter and to submit prior authorizations, or whether they're accessing our APIs. And so in both of those cases, we're doing kind of that trust and verification. My expectation is someday that's going to be a TEFCA model or something similar that's going to be larger than just us. But I do think that's the model going forward. When we've talked to individual payers and they start talking about how they're going to actually manage the connectivity, like, oh yeah, well, I'm reaching out to our top 10 providers in our state. I'm like, great. What we see in our portal today, when we're looking at all the submitters, about 40% of the submitters are not large health systems or multi-specialty groups. It is your ambulatory surgery centers. It is your, freestanding diagnostic imaging center. It's your chiropractic. It's your dental centers. They all submit prior authorizations too. And the payers have to realize that to really have this work, it can't all only work for your top 10 health systems in your state. It also has to work for that billing service, for that independent provider office, that specialty office that's there. And so trying to really build out that skill is going to be important.
Yeah. I think it's also interesting to look at it from, you guys are betting on, and in terms of availability, and from your personal experience, you can tell me which one you agree with, but I think availability is betting on the connectivity as an infrastructure, right? So you're enabling this infrastructure, and availability is not you guys are not a queue hen, right? You just are a network.
Right.
Am I correct?
Yep, you're correct on
And
that.
thoughts on some of it is that I'm more of like on the patient centric side. So I want to say I think patient has to have a seat at the table, and also like the provide leverage in terms
Hmm.
of being part of the solution. Being that you are primarily in between the organizations helping there, how do you feel about, you know, patient and then sharing data with the patient, and what level of access should patients have to their prior
Yeah.
auth data? You know,
Yeah, I think you're right. The patient is often stuck in the middle between payers and providers. And when you talk about getting involved with your child about like, hey, the prior authorization didn't go through and it took weeks to get it done. Like it's hard for you to know the current status, and I think one of the APIs that they're talking about is that patient access API as part of this CMS 0057. It will be interesting to see if that does kind of grow. We know that previous versions of it haven't grown. The authentication and getting individuals to have download a specific app that works just for them can be challenging. That being said, I think patients need to have access to their data and needs to be see the status of their prior authorizations. I think with that model, how we get there is really interesting, and I do believe that in generally the payer is going to have that information. Part of that is that information has to then flow back, whether it's in their own portal, whether it's in I know for my insurance company, I have an app. And when a claim is paid, I get like a notice that says, "Hey, your EOB is here," and I often know how much I'm going to owe my provider before I get a bill from a statement from my provider. And my expectation is, my hope is that that same process happens with prior authorizations, that you're seeing that information the same way you do with your EOBs. You're seeing that same information in your payer's app, or you're seeing it in your MyChart message or in your provider's application. I think that's going to be the important pieces. Those are the two groups that have that data, and those are the ones that are moving kind of the ball forward towards the goal of getting that authorization approved. I think those are kind of the two pieces. What we're also seeing cases though, and as you're probably aware of this, is that hey, the service is ordered in one facility, but is actually being performed somewhere else. And if you're in the same facility, that works great. If you're all under that same large health system, that works well. But there's also a second handoff that has to happen, that, hey, now I got approval. Now I have to go talk to this person over here who knows nothing about the prior authorization, wasn't involved at all, and now needs to like, am I getting paid for this? And so I think there's another set of handoffs. So more and more the ways that a providers can get access to that payer data to know here's the current status for this member, for the member that I'm treating. I think that's going to be really, really important. And so not only using the prior authorization, cool, now I have an approval. Now, how does the provider who's actually performing the service actually know that that prior authorization is approved, and how do I get all the clinical data I need so I can treat that patient well? I think those are all of these pieces start to fit together as you're building out these fire networks, and I'm super excited about that.
yeah, I can definitely tell you, like, I got the notifications from Cigna on when that prior auth, like, didn't go through, and there was like,
Okay.
I had a hard time, and even like with my level of knowledge, people say like you need a PhD in health policy to be able to like understand some of these things. But also like it was weird because they were like almost telling me like, here's what your provider didn't do,
Hmm.
and like it seemed like, yeah, basically the provider screwed up. So I had to go
Hmm.
back and I copied it and I sent it to my provider, and thankfully I had their email, and I was able to
Hmm.
like add them an email, and they were able to like call me back and like ask questions, and it didn't seem like they even knew. I knew before they knew that the prior auth was not properly submitted, and it was very kind of odd. And I'm like, how does this work in the ideal scenario? Would I even want to be notified if something like I would want them just to figure it out and like just let me know yes or no,
Hmm.
did you get approval or not? And but in this case particular, like I was the one that have the interest in getting this medication approved for my kids, obviously, because I feel like that's what they need. And so it raises an interesting question of, do you need, it's like agency, right? Like we as patients have, you know, a skin in the game because it's
Hmm.
our lives, it's our health. So like, should we be part of this prior auth process, right?
Yeah, I think
Interesting
that's a
question.
hard one. Yeah, I think that's a hard one. I think I agree with you. My mom is in her 80s. I have a father-in-law that's older, and we're definitely helping them with their health care. And so I definitely know there's cases that they get a notice and it's like, oh no, what do I do now? And it's like, nope, that's okay. You don't have to do anything. They're just like notifying you that the process is working. But then there's other cases where something's happening. There's a whole bunch of reasons why, a provider may not know about the current status of their authorization. Might be coming back on fax, might be sitting on the fax machine that somebody has to process it, might be sitting in the portal and somebody has to go log into a portal to pull that down. So a lot of this gets addressed much faster. In an ideal world, what you really want to have happen is that you just get addressed up front. If your provider knew before they submitted that here were the pieces of clinical data that is needed, here is the medical policy that's being used, I think the submissions start to be better. That's not going to happen day one, but I think what we are going to start to see is more of that information going into the provider's workflow. And so what you start to picture is if the provider knows those clinical questions that are needed at the time of ordering, what does that look like? And then if that clinical data can be gathered and submitted in real time, what the payer can start to do in real time, leveraging in some cases AI, is actually approve that authorization. Maybe the provider has to answer a handful of questions and then submit that back. We have a product called Auth AI, and what we're seeing is about 78% of the time that initial submission is getting approved kind of within 60 seconds. And so what you start to do is as long as you have that clinical data that's submitted as part of that process, then you don't have a checkout process. You're not going back and forth. If the provider knows right away, hey, this is the information that's needed, part of our process today is we're saying, hey, here are the questions that you're missing. Do you want to upload more clinical data? Do you have more clinical data as part of this? We'll automate more and more. And so we're actually, as part of that question process of informing the physician about their or the provider about their missing clinical data, they have the ability to upload more because sometimes the providers just don't know what's all needed. They may not be up on the latest medical policy and the latest research on kind of what's needed to get it kind of over the line. We had a case where provider had great documentation, had everything done. Payers medical policy is they've had physical therapy for the last 6 weeks. Provider documented they had physical therapy, they've had 5 visits, but didn't say how far apart the visits were. Did it cover 6 weeks? Did it not cover 6 weeks? You know, and so, but the payer's policy is really specific. And so it's like sometimes provider did everything right, but didn't just write one sentence. And then what you start to do is, boy, is there other ways payer can get this data? Could the payer start going looking at claim data? We have access to claim data. And so it starts to be like, how do we really start to improve this process that it's not up to the provider to give all the information to the payer? In reality, payer has more information than sometimes they let on, and oftentimes could say like, oh no, I did. Yep, you did have physical therapy. I can see that. I can see a claim. Why would the provider need to submit that type of information? And so those are what we're going to start to see those different models going forward.
Yeah, I feel like that's like the most frustrating thing being in healthcare for so long and just seeing that the data exists for all of this, right? Like we've had the data, it's just that it's not shared.
Hmm.
And this particular process runs in its own kind of like siloed way. And so hopefully prior off this particular, set of APIs will start closing the loop where, it's just the systems are talking to each other. And then the answers are somewhere within the system and are accessible to the actors that are trying to make these decisions regarding what gets approved. So ultimately, it all comes down to money, right? Because there's a limited amount of, if we in our ideal world, we would need prior auth because we would just have all services covered, but we know that that's not possible. So there's all kinds of different, rules in place. And so it sounds like really January 2027 is going to be a starting point, right? I don't think it's going to be a finish line for payers. And is that basically like, yeah, the starting point and then learnings after that? What do you think is like the toughest problem to solve that's still not solved that you've seen that you've had to debug maybe over
Yeah,
the
I mean,
last over a weekend where you wish you
over a
were
weekend. Yeah. I
there?
mean, I think what we really start to see is payers over time have made some pretty complex utilization management systems. And so we say, oh, just send the prior authorization to the payer. Payers in some cases has used what's something called a delegated vendor. So use other vendors who carve out a portion of their services to help better manage it. An example might be genetic testing. There's some utilization management groups or vendors that are just like, I'm really good at knowing like what the latest research is in genetic testing. So you don't need every payer to know. You can say like, nope, I'm not an expert in genetic testing. Instead, I'm going to have this group that the payer is going to contract with to manage that. But now in this workflow, the payer has to realize, oh, this transaction actually have to go to my genetic testing group, who's a whole different vendor. So it's not just getting it to the payer's front door; it's getting it to like the right group inside the payer. I think is going to be really, really interesting. And we've seen now in genetic testing, there can be home health, there can be durable medical equipment, there can be diagnostic imaging. There's a lot of these groups that are kind of out there. So I think that's one thing we're seeing, and that's going to be a challenge. I'll say the second thing we're seeing is there's definitely some state laws and state mandates that are a little bit different than the federal, or different states have done different things. California has a process of sending things back to the primary care provider for approval, those IPAs. And so how do those get routed in this new model? Because that's actually kind of like an EHR. So now I'm sending to the payer and then I have to route it back to an EHR, but the EHR actually needs to be able to take in an authorization request and approve it. So there's those types of workflows that get to be really, really interesting over time. So I think you're kind of the happy path, a transaction going from the provider to the payer. My hope is it's going to be pretty successful. And we're going to see some really good utilization there. And then we're going to have all these one-off use cases that like, oh, this specific EHR isn't quite ready for this version yet, or this specific payer for these specific services isn't quite there. I'm speaking almost the same as some of behavioral health. Many payers have separated out their behavioral health a long time ago, have not moved that back in. And so is that behavioral health workflow going to work kind of in that bigger picture? I think there's a lot of those types of little pockets that are going to be out there. So I do agree with you that that 1/1 is kind of the start date. I think expectations should be that we're going to get connectivity. We're going to see some transactions going forth. Most of them are going to be successful. And there's going to be some cases where the payer is going to say, hey, you still have to go use your old process. And over time, the number of cases where the payer says you have to go use your old process is going to go down and down as the integrations build out. And so I'm excited about kind of where we're headed. The last thing I'll add is CMS did put out that the state Medicaid programs do have an exemption, although they were originally scheduled for 1/1. I think some of the states talked to CMS and says, hey, we need a little bit more time. And so if you were hoping to connect to your state Medicaid program day one, follow up with your state to see where they are in their process. And so I think those would be the other areas that I'm at least aware of where it's going to be like, might take a little while for things to kind of get 100% rolling on every use case.
Yeah, and it's kind of complex. I know, particularly in example of PA, like there's a behavioral health carve out, so
Yep.
it's a completely separate system, and it can't it can't be you can't access it with the same access requirements. So okay, great. Well, Mark, really fascinating to talk to you, and yeah, would love to have you back on in like a year to see how this went and
Yeah.
how much progress we made. How are we starting to recoup that? What is it, $15 billion that folks have said potentially is something that we could recoup? And
Uh-huh.
I'm a big fan of like progress and like new fire-based solutions and all of that. But I also am like, how do we take costs out of the system and not just add it? Well, it's one of the things is like implementations of, processes like this that start replacing those legacy processes. Like the last thing we want to do is have two parallel processes now running and making it even more complex and add a cost to the system, right?
Yeah. I mean, I think last metric I saw was like a manual submission on a prior authorization is something like $9 per submission, and electronic is like 25 cents. And so that's the administrative burden that we're talking about addressing. And I think the last thing is that this is not, and we've talked about the patient a lot in this conversation. This isn't just about like, hey, let's get transactions going back and forth. There's some real patient needs that are being delayed, real patient care that's getting affected by prior authorization. It's been in the news for a long time. It continues to be in the news. It's one of the biggest pain points that providers talk about. MGNA put out their latest survey just a few months ago and left that out, and knows that we have our own process that we've used looking at this type of information. It is something that can really make it change, updating to these new fire specifications.
Okay. Well, fantastic. And thanks for all you're doing to forward this in the industry. Thank you very much, Mark, and have a good
Okay.
rest of your day.
Yep. You too. Thank you. Yep. Bye.